know that I like to talk about growth. So again, I'm going to apologize in advance with our adult colleagues because we are talking about like growth, specifically the treatment of short stature. So I gave a similar presentation. Yeah, it does come back. Okay, there you go. So I guess it's relevant for the fellows too, so that's good. About 6 years ago, I gave a similar presentation, but surprisingly, things have changed a lot in 6 years. The hot topic back then was long-acting growth hormone, and we have a few new treatments that are being used and a few that are like under investigation that seem promising. Because for many, many years, the only thing that was available to like treat short stature was growth hormone, and now things have changed are changing. So I do have a couple of disclosures. I am a PI for a couple industry-sponsored trials, and we'll be discussing some of their products. And I will discuss the off-label use of certain medications as well. So we will talk about the history and evolution of growth disorder treatments. Again, this is going to be like specifically about the treatment of short stature. I will review traditional and emerging therapeutic approaches. And we will talk about the clinical effectiveness and future potential of the current and some of these new treatments. So these are the things that I will discuss today. So we'll talk about the history of growth hormone that I really find fascinating. We will talk just a couple of slides about recombinant or traditional like growth hormone, the safety and efficacy. A couple of slides about long-acting growth hormone formulations that now we've been using for a few years. I'll talk about IGF-1, GnRH agonists, aromatase inhibitors, CNP, and LUM-201, which are two newer medications. Right, so I will start with the history. So this all started in 1912 when Dr. Harvey Cushing, that is well known because he obviously described like Cushing syndrome, but he published this paper. The title was The Pituitary Body and Its Disorders, and he introduced the term of hypo and hyperpituitarism here. He also mentioned that short stature and tall stature were associated with structural changes in the pituitary gland. And he, for the first time, describes this hormone of growth that was secreted by the pituitary gland. And then in 1921, Herbert McLean Evans obtained extracts from the anterior lobe of the pituitary gland of bovine pituitary gland. And then he did some experiments with rats, and he found that by injecting those extracts of the pituitary into rats, they grew. And he's actually considered the founder of growth hormone. Then in 1934, William Engelbach did research actually in humans. So he attempted to treat children with what we think children that had actual growth hormone deficiency with what he actually called growth hormone. And he reported increase in growth with bovine growth hormone in patients. Like now, years later, it was shown that this actually wasn't effective, but at that time, he noticed reportedly some improvement growth of these children. And then in 1958, Dr. Maurice Robin, he actually started treating growth hormone deficient patients with growth hormone that was extracted from cadavers. And this actually became the standard practice for the next 30 years. So this is a fragment of like one of these papers where they reported treating a 17-year-old male with they describe as a pituitary dwarf for 10 months. So it's interesting that he was 17 years, like most 17-year-old males are done with growth. I assume this child probably also had other pituitary deficiencies. And they reported that over that 10-month period, his growth velocity improved from 0.5 inches per year to 2.6 inches per year. So pretty good. Okay, so now we enter the pituitary human growth hormone era that, as I mentioned, like lasted about like 30 years. So in 1961, the NPA, or the National Pituitary Agency, was created to collect pituitary glands from cadavers. So this like agency like organized and guided the collection, extraction, and distribution of all the human growth hormone in the US and a little like internationally as well. So between like 1963 and 1985, like the NPA like actually supervised the treatment of around like 7,000 children in the US and over 25,000 patients like across the world. Then by 1965, these pituitaries were being collected by the medical examiner's office and they were shipped to the NPA. But this all was kind of like a donor system similar to what we have for blood donations right now. And this is interesting, and I just like decided to include it. But the dinner was being paid $2 per pituitary gland, and supposedly this one person like used like all that supplemental income to like build a pool in his backyard that he called the pit. I don't know how much of that is true, but that was interesting. Then in the late 1970s, the Swedish company Kabi like actually contracted with like various hospitals in Europe to like collect pituitary glands, and they developed like the first commercial product that was called Crescormon. Obviously, there was some conflict with the National Pituitary Agency here in the U.S. and then this European company that was like commercializing growth hormone. This also was marketed towards like general pediatricians. So their slogan was, "We set the standard, you judge the need." So they were also like trying to like bypass specialists, which also was a little problematic. They did put a warning on their label that there was a very rare potential risk of infection with the use of cadaveric growth hormone. Specifically, they mentioned hepatitis here, which was interesting. And then this I also highlighted because I thought it was very interesting that they say that if the growth velocity declines after 2 years of treatment, you can do like a washout period and stop the treatment for a few months, and then the growth velocity like improves again. But then only a few months later, this happened. There were 3 like young men that were diagnosed with Creutzfeldt-Jakob disease, and it was associated with the use of like this cadaveric growth hormone. And then after there were like many other cases that were reported. So this was published in 1985 in the New England Journal of Medicine. And then after this, the pituitary growth hormone era, like that was the end. So now during that time, this group of researchers, they had been working on trying to like isolate and purify growth hormone from various species. So Dr. Cho Hao Lee in 1962, like he actually like figured out the amino acid composition of growth hormone. A few years later, figured out the primary structure, and he worked for several years on like trying to synthesize like chemically like growth hormone, but he was never really able to do a growth hormone that was biologically active. Now in the 1970s, with a combination of Herb Boyer's restriction enzymes and Stanley Cohen's bacterial plasmids, with that technology, we basically had the ability to like amplify virtually like any gene. So in 1976, they were able to clone and express the human growth hormone gene, and then from there it was like relatively easy to like produce recombinant human growth hormone. A couple of years later, they were able to do the same with insulin. And then by 1985, we had 2 products. So we had recombinant human growth hormone, that is what we use today, that has 191 amino acids. And then we had the MET growth hormone that had an additional amino acid. So, and these were the 2 products that were initially available. So now from there, in 1985, recombinant human growth hormone was initially approved for the treatment of growth hormone deficiency. And then that was followed by the use in chronic kidney disease in 1993, then Turner syndrome in 1996, Prader-Willi syndrome in the year 2000, then for SGA children with poor catch-up growth in 2001, idiopathic short stature in 2003, Shocks deficiency in 2006, and then the most recent was the use of Noonan syndrome in 2007. So I'm not going to talk too much about recombinant human growth hormone because we've been talking about that for several years. I'm just going to talk about like these couple of like recent publications. So this is the most recent report from the kids cohort that was published in 2022. This is this like giant observational, like multinational registry that includes over 80,000 children that are receiving growth hormone for different FDA approved indications. And we know that it works, and obviously it works better for those that have growth hormone deficiency. So children that have congenital growth hormone deficiency gain typically 2.5 standard deviations, and that is followed by isolated growth hormone deficiency that they gain close to 2 standard deviations. Then children that are SGA with poor catch-up, usually not as robust, so they'll gain like 1.3 standard deviations, which is similar to like children with idiopathic short stature. And then Turner syndrome, that obviously has a very different mechanism of like why girls with Turner syndrome are short. They gain about like 1 standard deviation in treatment. Safety. So overall, we know that growth hormone therapy is typically very well tolerated. And this is, again, looking at greater than 500,000 patient years of exposure to growth hormone. So I mean, we have like pretty strong data to say that it's a safe medication. The main adverse events are those that we already know about, benign intracranial hypertension, which is very rare and happens in less than 1% of patients. We can have glucose metabolism changes, less than 1%. SCFE has been also reported a little more often, but extremely rare as well. And there's always been the concern for cancer risk, right? Because we're giving growth promoting factors, and we don't really know if it's going to promote the growth of other things. But overall, we know that it does not increase the overall risk of cancer incidence, but they recommend that we use it with caution in those patients that have a history of malignancy because they already have increased risk of having recurrence or secondary forms of cancer. When it comes to long-term mortality after the use of growth hormone treatment, this is also a relatively recent report. So the SAGE cohort, their most recent report is from 2020. And these included close to 25,000 patients that were treated with growth hormone between 1984 and 2010. So the median follow-up for these kids is 17 years. Overall, these kids have slightly increased mortality when compared to the general population. So the standardized mortality ratio is about 1.1. But obviously, you know, the important part here is that the risk for those that have isolated growth hormone deficiency or idiopathic short stature is the same. So it does not increase the overall risk of mortality. Now, in patients with other diagnoses, so those that are born small for gestational age, for whatever reason they were small, those that have a chronic diagnosis or a genetic syndrome, so they have higher SMR, so 1.5 for SGA and 3.8 for chronic diagnosis. And then obviously those that have a history of malignancy, well, the risk is very elevated at 17. And they also concluded that mortality was not associated with the mean daily or the cumulative dose of growth hormone, which I think is reassuring as well. Okay, now I'm going to move to the long-acting growth hormone preparation. So in general, we know that drugs don't work in patients that don't take them, right? You have to really take these medications to work. And some studies have actually shown that as few as 30% of patients like demonstrate good adherence, and by good adherence they mean that they're missing less than 1 dose per week. So the goal of like creating these like long-acting formulations is that by decreasing the frequency of the injections, you know, we can improve patient adherence, and hopefully the patients will stay on the medication longer, and then potentially we will have like better outcomes. So the first attempt at creating a long-acting formulation was Nutropin Depot. It was approved a long time ago in 1999. This was actually a monthly formulation, so different to what we have right now. So this was basically recombinant human growth hormone that was adhered to like these like microspheres that just resulted in like sustained release of the medication over a 1-month period. I think in some rare occasions it was dosed twice a month, but in general it was once a month. However, they had a lot of issues with adverse events at the injection site. So I think the volume was large. Sometimes they had to give like large doses. lots of reactions. Sometimes like multiple injections were actually needed. And then it was not very successful. So a few years later, it actually came out of the market, and they had a lot of issues with like manufacturing the medication. But now we have several different brands that are on the market. They all have like slightly different mechanisms to like prolong the action of growth hormone. All of these are actually weekly formulations, and they have shown to be as effective as the daily injections. So we have somatrogon or Nangela, that is basically the same amino acid sequence as like the recombinant human growth hormone that we use right now with the daily injections, but then it has an additional C-terminal peptide that is what prolongs the action. The dose is actually a lot higher when compared to what we're used to use. Usually like we'll use like somewhere between like 0.16 to like 0.3 milligrams per kilo per week, depending on what the diagnosis is. And for these in children with growth hormone deficiency, they recommend to start at 0.66 milligrams per kilo per week. I mean, I'm going to try to pronounce these. Lonapexomatropin or Skytrofa has a different mechanism to prolong the half-life by attaching a methoxypolyethylene glycol carrier. The dose is actually similar to what we use with the daily injection, 0.24 milligrams per kilo per week. And then the last one that we have available right now is somapacitan or Sogroya, that also has a slightly different mechanism to prolong the half-life. And the dosing here too, I would say similar to what we use for like the treatment of growth hormone deficiency with daily injections, so 0.16 milligrams per kilo per week. Now, the initial studies of like some of these medications like actually showed that they were potentially superior to daily injections with somatropin. So with somatrogon or Nangela, the high velocity was 10.1 centimeters per year versus 9.7 with somatropin. And then with Skytrofa, the high velocity was even better, 11.2 centimeters a year versus 10.3 with the somatropin. What is interesting here is that the adherence rates were different because we're similar. They were not any different because we're talking about a research study. So typically adherence with the daily injections is much better than real life. So we cannot say, oh, it was because it was once a week versus daily, because like the adherence in these studies was similar. So they think that potentially this was due to like increased engagement of the growth hormone receptors at the level of the growth plate and potentially higher mean IGF-1 levels. Now, all of these long-acting growth hormones have similar patterns of pharmacokinetics. So the peak after they get the injection usually happens around 12 hours. The peak IGF-1 level like usually happens at 48 hours after the dose is given. And then the mean IGF-1 level, which is really the one that we're more interested in, usually happens like 4 days after the injection is given. So ideally, for monitoring purposes, like we want to try to get an IGF-1 level like 4 days after the injection was given. Now, some of these drug companies like have actually created like this algorithm that helps us to like calculate what the mean IGF-1 level is like, regardless of like when the level was obtained, just so we don't have to have the patient like go back to the lab and get another blood sample on day 4. So that makes it easy. Okay, so that's all I have on like long-acting growth hormone. Now I'm briefly going to talk about IGF-1. So recombinant human IGF-1 was a hot topic in the early 2000s when it was being developed. Everybody thought that this was going to be even better than growth hormone, right? We're even like skipping growth hormone. We're just like going straight and giving IGF-1 to these patients. So initially, like they thought that this was going to be huge and it was going to like really help everybody to grow. So they did a lot of studies, not only on patients that had IGF-1 deficiency, like I'll mention later, but in patients with growth hormone deficiency. They studied it, I think, in like type 2 diabetes and like multiple other conditions. And in 2005, recombinant human IGF-1 was approved by the FDA for 2 very specific indications. So one of them was growth failure in children with severe primary IGF-1 deficiency. So these are patients that have a mutation in the growth hormone receptor or Laron syndrome. or patients that had growth hormone gene deletions. And these patients typically actually develop antibodies against growth hormone. So if we treat them with just a regular growth hormone, these antibodies will neutralize it and it doesn't work. So IGF-1 obviously makes sense because we're bypassing that step. So,
What's the price?
oh, very expensive.
Very.
Like I mean, growth hormone, I know that can be, I don't know specifically for like Increlex, but I know
Yeah.
that growth hormone, like the cheapest that we can typically get is around like $20 per milligram. You know, and these children are needing anywhere between like 1 to 3 a day. So out of pocket is very, very expensive. And like Increlex has to be obtained directly with the pharmaceutical company. Like you cannot really get it at pharmacies, not even with like specialty pharmacies. And I assume the price is similar, but I'm not sure. Now, Increlex is a shot that is given twice a day. So that's another thing that is right. Yeah, no, and I have seen, not here, but where I did my fellowship, like I saw several children with Laron disease being treated with Increlex, and you know, I can't remember what was the name of the pharmaceutical company that owned it at that time, because I think it changed recently, and like most patients didn't have an issue getting it. And initially there were two products that were available, so Increlex and Iplex, but then in 2007, Iplex like actually came out of the market. So this is specifically for children that have growth hormone insensitivity or Laron syndrome. These are again some studies from like the early 2000s. And it works. I mean, those kids that were treated with recombinant IGF-1, like this is pre-treatment, so they were growing like 2 to 3 centimeters a year. And the growth velocity in the first year is like robust and improves to around 8 centimeters a year, which is really good. And then it declines a little bit and stays around 5 to 6 centimeters a year. But typically these children gain 2 to 2.5 standard deviations if they're treated for 5 to 7 years. This is just like a little summary of like different studies that use like various doses of like recombinant IGF-1. Pre-treatment growth velocity was between 3 to 4 centimeters a year, and then post-treatment was typically around 8 to 9 centimeters a year in like all of this. Now, recombinant human IGF-1 does have I would say, a more significant like adverse event profile. So hypoglycemia is a big one, especially like in babies. So like younger kiddos that are treated, kiddos with Laron syndrome, but that are treated with Increlex, like tend to have issues with hypoglycemia. So it has to be given with a meal and at the beginning, and when they're increasing the doses, it's important to like monitor blood sugars. Lipohypertrophy is an issue as well. Tonsillar hypertrophy, which obviously can be an issue for like sleep apnea. Injection reactions, headaches, intracranial hypertension. And the biggest reason why this is not so popular and why they have actually stopped trying to like investigate other uses for this growth is that it has been associated with benign and malignant neoplasms in patients that are receiving, one, higher doses than recommended, and two, when they use them for off-label uses. Okay, now, so that's all I had in with recombinant IGF-1. Now I'm going to talk about GnRH agonists. So GnRH agonists are typically used, and they're approved by the FDA to be used for the treatment of central precocious puberty. But I would say historically, they have been used in certain specific cases to improve growth in short children. So this is a very well, I shouldn't say very old, but this is a paper that was published in 2003 in the New England Journal of Medicine, where they basically treated short patients that had like maybe earlier than average like onset of puberty, but not necessarily precocious puberty, and they just exclusively treated them for like growth purposes to see what happened. So these kids were treated for 3.5 years, and they noticed that after that period of time, like their height improved by 0.6 standard deviation. So the total gain was only about 4 centimeters. And then during this period of time, one of the risks is that it can actually decrease like bone mineral density, although like long term that seems to improve. So what they concluded after this paper in 2003 is that they cannot like routinely recommend this treatment for adolescents with short stature that have normal puberty. Then this was published in 2016, and this was actually done in 76 prepubertal short children that were born small for gestational age. So what they did in these studies that they divided the patients in two groups, those that were less than 140 centimeters at the onset of puberty and those that were taller than 140 centimeters. And the ones that were shorter were treated with growth hormone plus GnRH agonists, and the ones that were taller were treated only with growth hormone, and then they compared. And actually, the group that was treated with the GnRH agonist that had a really poor growth potential to begin with, like they ended up having a really decent gain of like 6.6 centimeters. And then the final adult height was actually similar for both groups. So in this case, it seemed to help, but it was used in combination with growth hormone. Now, this is a very recent publication from 2023. And here they treated a small group of like early pubertal girls that had a projected adult height that was below -2.5 standard deviations. And they treated these girls for 4 years with growth hormone plus GnRH agonists and then compared them to controls. And what they found was that their height like actually increased from 131 at this onset of treatment to 159 centimeters at the end of treatment. So like, I mean, that's like 5'3" probably. So I think that's right. So close to that. So I think it's a pretty normal adult height. And then in the control group, the height increased to 130 from 132 to 153. So the adult height actually surpassed the initial predicted adult height by 12 centimeters in the girls that received both treatments, and then by 4 centimeters in those that only got the growth hormone. So I think in this particular situation, it also seemed to help, but it seems like as a monotherapy, like it really didn't do much. So these guidelines that were updated in 2019 for growth purposes, this is what they recommend. They recommend the addition of GnRH agonist could be considered in patients that are treated for malignancy, that, I mean, they have resultant growth hormone deficiency and central precocious puberty. So like that one I think is obvious because they have central precocious puberty. Children that have growth hormone deficiency who have not experienced significant catch-up growth at the onset of puberty, and SGA children who are very short at the start of puberty, so they're less than 140 centimeters, which is similar to that other paper that I presented, and have a poor predicted adult height. Okay, now I'm going to talk about aromatase inhibitors. So we know that estrogen is the principal modulator of epiphyseal fusion, even in males. And for many, many years, aromatase inhibitors have actually been used off-label to treat short stature in adolescent males. So the mechanism is that basically by blocking aromatase, we block the conversion of testosterone to estrogen. And then since we have like lower levels of estrogen, then we can slow down the bone age progression, and then patients have more time to grow. So currently there's two that are used. So we have an anastrozole that inhibits about 97% of like aromatase action, and then we have letrozole that is a little more potent, inhibits 99%. So there have been some studies basically looking at how effective aromatase inhibitors are to improve growth. I think this is a very interesting one that was published close to 10 years ago. They took like 76 pubertal boys that had idiopathic short stature, and they receive either aromatase inhibitors alone, they receive growth hormone, or they receive aromatase inhibitors plus growth hormone combined. They did not have a control group, so it would have been nice to have a group that received nothing, but they didn't have that. And they found that after 2 years of treatment, in the aromatase inhibitor group only, those kids gained 14 centimeters. Growth hormone only, it was better. They gained 17, and the combination gained almost 19. And we can see that here in this graph, and it was significant. So like in combination, it seemed to be pretty good. And then the bone age maturation obviously was slower in those that received aromatase inhibitors. Now, this here is a meta-analysis looking at aromatase inhibitors for the treatment of short stature in male children and adolescents in combination with growth hormone. So for this meta-analysis that was published just last year, so this is very recent, they included 8 randomized controlled trials that included over 400 participants. And they showed that basically the combination of aromatase inhibitors with growth hormone had some additional benefits. Growth velocity was a little better by I would say a lot better by 3 centimeters. Predicted adult height with the combination was also better by 5 centimeters. And the bone age progression obviously was lower. So typically these patients have a more delayed bone ages. They also mentioned that I found interesting, but they said that the differences between the groups for IGF-1, estradiol, serum testosterone, and overall, like the adverse events reported were not statistically significant. This other one is a recent study that was published in last year, 2024. And this was an open label trial, no treatment arms. They just grabbed like 79 prepubertal males with idiopathic short stature, and then they treated half of them with letrozole and then the other half with anastrozole. Again, there was no control group, but they just look at the difference between both groups. And what they found is that the group that was treated with letrozole had overall higher testosterone levels, lower estradiol, and IGF-1 levels were lower as well, and they overall had like slightly lower growth velocity and bone age advancement. Now, the change in the predicted adult height from baseline was actually not different between the two groups, and in both groups combined, the gain over 3 years of treatment was only 1 centimeter. So like overall, this seems like just using aromatase inhibitors is not very effective. And that's what like most of the studies like tend to show, like there is potentially some benefit, but it's very, very limited. Okay, so just to summarize here, so like some practical considerations with the use of aromatase inhibitors. They can be considered for the treatment of pubertal boys that have severe short stature with heights below -2 standard deviations, with a bone age that is at least 12, but no older than 14 and a half, because obviously those growth plates have to be open for it to be effective. It is preferred in combination with growth hormone. These authors that have published a lot on this topic actually recommend that we obtain a baseline testosterone, excuse me, estradiol, a bone age, and a DEXA scan that I feel like most of us, at least in our practice, don't typically get a DEXA scan, because there is the potential to like decrease the bone density. And in those patients that already have a low bone mineral density to begin with, we should be extra cautious if we want to use aromatase inhibitors. Now, the overall risk profile is a little better with anastrozole versus letrozole. So anastrozole 1 milligram daily is preferred. And they recommend that we limit the use to no more than 3 years. Like all these studies have actually been in like 2 to 3 year period. When it comes to the safety profile, so we know that that prolonged estrogen blockade can actually impact bone mineral density. So in the very like first studies that were done on the use of aromatase inhibitors, there were concerns for like vertebral irregularities in some patients. This was more common in like kids that were prepubertal, so that's one of the reasons why we don't use it in prepubertal kids. But overall, when used for 2 to 3 years in kids that have normal onset of puberty, there seems that there is not much of a long-term negative impact on bone health. There's no impact on fertility. There's no significant impact on lipids, LFTs, and blood counts. And I always warn my patients that it can make acne a little worse, but it does not typically result in discontinuation of treatment. Yes.
Does it depend at all on the age that it started, on the age of the child?
What?
The aromatase inhibitor, I mean,
the bone density?
yeah.
So typically,
No, I mean, for the overall effect, the longer
Yeah.
you go on.
so you want to start it, like you have a very limited window where you can use them and when they're actually effective. So you want to use it in kids that are in early puberty, but not too advanced that the bone age is older than 14 and a half. So usually this will be like the child that is between like probably 12 and 14 years. No, no problem. All right, so that's all I had. Off-label, yes, off-label use. Yeah, they're actually like FDA approved for breast cancer, so aromatase is off-label. Okay, now I'm going to talk about CNP, C-natriuretic peptide. That is one of the newer medications that are available to treat very specific conditions. So CNP is a member of the natriuretic peptide family, but unlike the atrial and the brain natriuretic peptide, it does not have a role in cardiovascular homeostasis. CNP is actually an important regulator of longitudinal bone growth that acts through the NPR2 receptor, or like the natriuretic peptide receptor beta. So it would be, this is the receptor, this is CNP. So CNP actually stimulates endochondral ossification, which is the opposite of like what this pathway does. So FGFR3 and this pathway actually like inhibits like endochondral ossification, right? So basically, CNP like lifts the brake of this cascade, right? So it will inhibit this pathway and it will allow increased like growth. So now in patients that have achondroplasia, they have gain of function mutations in FGFR3, and that is the cause of achondroplasia. So this receptor basically is mutated, right? So these patients actually have increased FGFR activity, and FGF acts as a brake, which overall will inhibit growth by inhibiting this like endochondral ossification. Now, CNP will inhibit this pathway here at the level of RAF1, thereby easing the braking action of FGFR3 signaling, and then it will overall promote growth. So CNP was actually approved here a few years ago for the use for the treatment of short stature in patients with achondroplasia, and is currently being studied in like multiple other conditions that I'll mention. So this was the initial like phase 2 dose finding study that was published in the New England Journal of Medicine in 2019. They look at different doses of vosoritide, that is a CNP analog, in 35 children with achondroplasia. And they treated these kids for 42 months. And they noticed that the analyzed growth velocity improved by 1 to 2 centimeters per year. And then this was followed by a 52-week phase 3 trial that was double-blind randomized. And this included a larger group of participants. So here they had 121 children with achondroplasia between the ages of 5 to 18. And they used the dose that they had found to be more effective, that was the 15 versus placebo. And what they found in the difference in the two groups, those that receive vosoritide versus placebo. So placebo here is the pinkish, and then vosoritide is the purple. And the vosoritide group had an improved growth velocity of 1.5 centimeters per year. And then after this, vosoritide was approved by the FDA for the treatment of achondroplasia. That was in November of 2021. Now, there's been a lot of debate because it's only 1.5 centimeters per year. And we don't really know, we know that that's in the first few years of treatment, but we don't really know how effective it is after year 2, 3, 4, 5, right? And it is, I would say, a smaller amount of benefit. There is another form of CNP analog, the TransCon CNP, that is currently being investigated. So this one is conjugated to a polyethylene glycol carrier that basically will just extend the half-life. So this is a potential weekly formulation. So these are reports from a phase 2 trial using 100 micrograms per kilo per week, and they found that it improved the analyzed growth velocity similar to like the daily injections with vosoritide, and it was a little over a centimeter per year versus placebo. So like I mentioned, this is being currently studied for like multiple other genetic conditions that are in that same pathway that I showed in that initial, in that slide. So it's currently being studied for a hypochondroplasia that is also due to mutations in the FGFR3 gene, but in a different position. CNP deficiency, which I mean, I think this one makes a lot of sense. Defects in the CNP receptor, and this would be like heterozygous defects, because if you have homozygous defects, no matter how much you give, it wouldn't work. Resolopathies, including Noonan syndrome, SHOX gene mutations, and ACAN gene mutations. So these are the current things that are potentially in the horizon. Now, the last medication that I wanted to mention that is currently under investigation is LUM-201 or ibutamoren. So this is actually, like, of all the medications that I've mentioned today, this is, well, and I guess anastrozole too, but this is an oral growth hormone secretagogue. So this was designed to increase endogenous growth hormone release and pulsability, and it acts by stimulating ghrelin, the ghrelin receptors, and then that increases growth hormone releasing hormone and will actually suppress somatostatin, which overall will increase like growth hormone release. Now, the initial studies in pediatrics were not very promising. They thought that a very small group of patients just seemed to respond. However, they concluded after the initial studies that they probably just didn't choose the right population because they were using just patients with growth hormone deficiency, including those that have profound growth hormone deficiency and like anatomic defects that were just not even able to increase growth hormone releasing hormone. But based on those initial studies, they created this predictive enrichment marker that was created to basically predict which patients could potentially respond to treatment with Lumos. And they found that those that had mild growth hormone deficiency with a peak growth hormone level greater than 5 and IGF-1 levels greater than 30 were those that had a greater chance of like responding to these medication. Here in this, they actually look at the response of like growth hormone levels after giving Lumos, giving the LUM-201. And they found that the peak growth hormone was actually significantly higher versus like other standard growth hormone stimulation tests. Obviously, those that had profound growth hormone deficiency with very low levels on the standard growth hormone stimulation tests had a similar response to the LUM-201, but those that had higher levels on the standard had way higher levels on these level, and they mentioned that this could possibly be used down the road as an agent for the growth hormone stimulation test. So there's currently an ongoing open label phase 2 clinical trial investigating the effects of the LUM-201 at higher doses in prepubertal kids with mild growth hormone deficiency. And then they presented the preliminary data at Endo here recently, and they found that there were no significant outcomes between the 1.6 and the 3.2 milligram per kilo per day dosing. Both actually helped to increase the growth hormone levels and increase IGF-1 levels in these patients, and the analyzed high velocity improved to 7.8 centimeters per year after 12 months of treatment, which is good, but is not nearly as close to what we typically see in the first year with growth hormone. And they're actually in the process of starting a phase 3 study. So we'll see. That's all I have. I have a few minutes to take any questions.
So the fact that these long-acting hormones are continuous as opposed to having opposed to medications.
So there is still a significant variability in the IGF-1 level. So like I mentioned, like the IGF-1 level like usually peaks after 12 hours. The mean level, like there you'll see a peak and then, a slower decline.
If you're giving it once a month.
You give them once a week.
Once.
But the mean IGF-1 level is actually a little higher than what you get with like daily injections, and the response is supposedly similar. I think for us, at least
There was a.
with what?
than it.
Oh, with the pump. That would be interesting. Yeah. Yeah. Yeah, you could even time it to give higher doses at night, but yeah. See.
Hello, this is Swapna. I'm not sure if you can hear me.
Okay,
Swapna
so I have
Deo.
a question here. They asked, do you do growth hormone therapy plus minus an anastrozole in constitutional short stature if parents request? So this is actually, I would say not typically. I mean, I don't tend to do, what the parents request unless I'm like very concerned about the child. And I would say if someone has constitutional delay, like I just watched them, I tend not to treat them. I would say anastrozole has been used in combination with testosterone in kids that have constitutional delay. And the reasoning behind doing that is that basically you accelerate the onset of puberty by giving the testosterone, but then you don't really shorten their time to grow by giving the anastrozole. So I have seen some papers on using testosterone with anastrozole for constitutional delay, but I would say growth hormone with anastrozole is probably less likely to be used. I think that's the only
Thank you.
question that
Yeah.
I have here.
Well, I did have a follow-up that question. I don't know if you can hear me. This is Swapna Deo.
I can't hear you.
You can?
Yeah.
Okay. Thank you for that answer. So in those patients, so if you do testosterone plus growth hormone, you said, what is the long-term fertility effects with that therapy?
So
And how long do you do it?
children that have constitutional delay, we only use testosterone for a very short period of time. So you should not have a negative impact on fertility because, testosterone, we're just using it for about 4 to maybe up to 6 months. So this is just something that we're doing to like jumpstart puberty. So I would say no long-term effects on fertility. Does that answer your question?
Thank you. Yeah, yes. I mean, I know that you're monitoring the bone age at that same time, of course. So I'm presuming you stop before the growth plates fuse, or how does that work?
Sorry, no, I don't think I understood the question.
So you just basically you continue it for 4 to 6 months, you said, and at that time you're
Oh,
expecting.
testosterone, yes. So the
Yes.
testosterone we only use for 4 to 6 months, and then we watch the child and make sure that they actually progress with puberty. And this is typically in children that are like over 14 or 15 years that have very delayed puberty and are kind of like distressed by that. Now, I personally have never used an aromatase inhibitor with testosterone, but I did read a couple of papers about that.
Okay, thank you.
No problem. All right. Well, thank you, everybody.